Graves' disease. Graves' disease is the most common cause of endogenous hyperthyroidism. It is characterized by a triad of manifestations. Thyrotoxicosis, which is caused by an enlarged, hyperfunctional thyroid and is present in all cases. Infiltrative, ophthalmopathy with resultant exophthalmos in 40% of patients. A localized, infiltrative dermopathy which is seen in a minority of cases. Graves' disease has a peak incidence between the ages of 20 and 40, with women being affected up to 7 times more commonly than men. This very common disorder is estimated to affect 1.5% to 2.0% of women in the United States. Genetic factors are important in the causation of Graves' disease. The incidence is increased in relatives of affected patients, and the concordance rate in monozygotic twins is as high as 60%. Genetic susceptibility to Graves' disease is associated with the presence of certain human leukocyte antigen (HLA) haplotypes, specifically HLA-DR3, and polymorphisms in genes encoding the inhibitory T-cell receptor CTLA-4 and the tyrosine phosphatase PTPN22. Pathogenesis. Graves' disease is characterized by a breakdown in self-tolerance to thyroid autoantigens, of which the most important is the TSH receptor. The result is the production of multiple autoantibodies, including thyroid-stimulating immunoglobulin, an IgG antibody that binds to the TSH receptor and mimics the action of TSH, stimulating adenyl cyclase, with resultant increased release of thyroid hormones. Almost all persons with Graves' disease have detectable amounts of this autoantibody, which is relatively specific for Graves' disease. Thyroid growth-stimulating immunoglobulins, also directed against the TSH receptor, these antibodies have been implicated in the proliferation of thyroid follicular epithelium. TSH-binding inhibitor immunoglobulins, these anti-TSH receptor antibodies prevent TSH from binding to its receptor on thyroid epithelial cells and in so doing may actually inhibit thyroid cell function. The coexistence of stimulating and inhibiting immunoglobulins in the serum of the same patient is not unusual, a finding that may explain why some patients with Graves' disease spontaneously develop episodes of hypothyroidism. A T-cell-mediated autoimmune phenomenon also is involved in the development of the infiltrative ophthalmopathy characteristic of Graves' disease. In Graves' ophthalmopathy, the volume of the retroorbital connective tissues and extraocular muscles is increased as a result of several causes, including 1. Marked infiltration of the retroorbital space by mononuclear cells, predominantly T cells, 2. Inflammatory edema and swelling of extraocular muscles, 3. Accumulation of extracellular matrix components, specifically hydrophilic glycosaminoglycans such as hyaluronic acid and chondroitin sulfate, and 4. Increased numbers of adipocytes, fatty infiltration. These changes displace the eyeball forward, potentially interfering with the function of the extraocular muscles. Clinical features. The clinical manifestations of Graves' disease include those common to all forms of thyrotoxicosis, which is discussed in another video, as well as those associated uniquely with Graves' disease: diffuse hyperplasia of the thyroid, ophthalmopathy, and dermopathy. The degree of thyrotoxicosis varies from case to case, and the related changes may sometimes be less conspicuous than other manifestations of the disease. Increased flow of blood through the hyperactive gland often produces an audible bruit. Sympathetic overactivity produces a characteristic wide, staring gaze and lid lag. The ophthalmopathy of Graves' disease results in abnormal protrusion of the eyeball, which is called exophthalmos. The extraocular muscles often are weak. The exophthalmos may persist or progress despite successful treatment of the thyrotoxicosis, sometimes resulting in corneal injury. The infiltrative dermopathy, or pretibial myxedema, most commonly involves the skin overlying the shins, where it manifests as scaly thickening and induration of the skin. The skin lesions may be slightly pigmented papules or nodules and often have an orange peel texture. Laboratory findings in Graves' disease include elevated serum free T4 and T3 and depressed serum TSH. Because of ongoing stimulation of the thyroid follicles by TSIs, radioactive iodine